let's go ahead and get started. We're gonna we're gonna be recording this session today. I'm gonna ask Kara to get that started. My name's Katie Robert. I work for the Community Health Institute, JSI, and we are here today for a webinar, our third in a series of 4 webinars that our New Hampshire ECCS project has planned. The ECCS project is a partnership between JSI and New Hampshire Family Voices with funding from the Department of Health and Human Services to help strengthen early childhood comprehensive systems, and really focused on building strong connections between healthcare providers and community members. So today we're really excited to be joined by a pilot project team to talk about some of the exciting work that they've been able to test over the last 6 to 8 months. And so what we will be able to, what we're going to go through today is to talk about that innovative approach that was used by the pilot teams to foster collaboration and engagement between families and care teams around family care plans. Understand the methods used to evaluate the Family Care Planner pilot project. And then understand the strengths, challenges, and opportunities of the Family Care Planner approach to complement the implementation of plans of safe care. And as I had mentioned previously, but please feel free to add your questions to the chat throughout the session, and we will make sure that they are that they're answered to the best we can. So before I hand it over to my colleague Adriana to kick off the webinar, we wanted to share an exciting update that has come about with the funds provided by the New Hampshire ECCS project. Many of you may be familiar with New Hampshire Family Voices and their website, which is a very, very deep, robust resource for families and providers looking to connect with services in the state. And so the website has been historically around 4,000 pages. With some different levels of tagging that have gone on, and just over the course of time, the website became, just kind of became bulky. And so with funds from this project, the New Hampshire Family Voices team was able to is in the process of finalizing kind of a webification of the Maneuvering the Maze resource, which has been a paper printout resource to date, but it was an opportunity, was a way for families to find access or find information about different resources that they may need to support their children. And so you want to go to the next slide, Kara? And so, as I mentioned, the website, it was pretty large and bulky, around 4,000 pages of content with resources that were not always tagged. So it was not always easy to find things. And so over the last few months, the Family Voices team has changed, or will be changing, their website from this format. And now the website will be structured in such a way that families can go to that website, providers can go to that website. Go ahead, Kara. And they'll now be able to search for resources according to the different diagnoses that they might be searching for, the stage of development that their child may be in, the system of care that they might be involved with. So knowing that families are going into these resources kind of with different framing questions in mind, the team reframed this website and reframed this resource so that any of those kind of framings can be applied when they get to that website. So once families go in, they will be able to put in different search parameters and filters. There will be this visual card format to show those resources. And all of the resources that were listed in the Maneuvering the Maze tool previously have been updated and added and incorporated into the website, into this new resource directory. So the plan for Family Voices is to have the website updated to that, with all of the current information, but down the road, the intent is to have the website transitioned or programmed into an actual application that someone might be able to download on their phone and kind of access easily. So this is an exciting development for the Family Voices team for this project. And hopefully, if it's not a resource that you have been previously familiar with, you will be able to go and check it out. They're in the final stages of programming. They had a few coding and tagging things they needed to clean up on the back end, but we're hoping that we will have an announcement and a hard launch of the new website to share with folks in the next few weeks. So again, this was a big part of the project of the New Hampshire ECCS project. And so we wanted to make sure that we were using this time to help share this information while we have you all here. So I'm going to hand it over to my colleague, Adriana, who is going to officially MC the rest of the webinars. Thanks, Adriana.
Hi, everyone. Kara, could you advance the slide? So my name is Adriana Espitia. I am a Senior Technical Associate at JSI Community Health Institute. And we're going to be presenting about an innovative pilot. And I just wanted to acknowledge the team here. So presenting today will be myself, my colleague Hannah Lessels, and Rekha Srihara. And then from Concord Hospital, we have Rhonda Chase, Melissa Devine, and Angela Wilson. And from Dartmouth Hitchcock Medical Center, we have Megan Adams and Dr. Bonnie Whalen. And then we also just want to acknowledge the work of the larger teams that worked on this project at each of these organizations. Next slide. So could I just see just a second, if people could use the hand up feature or write in the chat, how many people have heard the term family care plan? Not seeing a ton of thumbs up. Okay. How many people have heard of the term plan of safe care? Few more people, it looks like. So they're the same thing. Plan of safe care is a legal term, but family care plan is the term that we are trying to use more broadly in New Hampshire to describe it. And just to make sure we're all on the same playing field, we're going to just show a short video explaining what the family care plan is. So, Kara?
Together, we can support infants and families in New Hampshire. Thanks to the dedicated physicians, nurses, social workers, home visitors, recovery coaches, and other professionals working in settings such as hospitals, family resource centers, and recovery community organizations. We are committed to supporting the health of birthing parents and their infants through a family care plan, also referred to as a plan of safe care or plan of supportive care. An interactive document for families that helps them identify and navigate existing supports and new services. The Family Care Plan is a living document that not only lists resources like pediatricians, behavioral health services, and other support services, but it also helps the family identify needs, strengths, supports, and goals. Any professional can help a family create a plan, starting prenatally and continuing throughout pregnancy, birth, and beyond. A family care plan is legally required for infants born affected by exposure to alcohol and drugs, including prescribed medications to treat substance use disorders. Birthing hospitals must notify the state when an infant is born affected by substance use, withdrawal symptoms, or fetal alcohol spectrum disorder. This is referred to as a notification for purposes of federally required data collection. The development of a plan and the notification process are separate from determining whether a report of abuse or neglect should be made to the New Hampshire Division for Children, Youth, and Families. A plan is beneficial for all people giving birth. Let's support infants and families across the Granite State with a family care plan. Start one with the families you serve today. Visit www.nhcenterforexcellence.org/POSC for resources and support. Together, we can support infants.
Thank you. And if you have any specific questions about the family care plan or plan of safe care, feel free to drop those into the chat as well, and we can maybe answer some of those during the Q&A. Okay. So as you all now know, or already knew, the family care plan is a one-page document that lists the resources and supports for families impacted by substance use. And as you may also know, it is a piece of paper that often gets lost in the shuffle with all the papers that families receive when they're pregnant or about to give birth or postpartum. So we decided to do a pilot where the family care plan is within a binder that can help not only provide information, but it's also a place for families to collect and organize all the information they're getting. It's an innovative approach that we actually copied or learned from New Mexico, Oklahoma, and Texas, where it's being implemented. And we want to emphasize, like the video emphasized, that like the plan of safe care or family care plan, it's useful beyond just families with substance use disorders. I think all families can use a little support during that time in their lives. And so we really want to emphasize that, although we did start with this population because that is the population that is legally required to have a plan. And Kara, it looks like I have slide control, so I'm going to just move forward. Okay, so a little bit more about the pilot. It's a 6-month pilot. It started in December and we're wrapping up this month. The organizations were Concord Hospital and Dartmouth Hitchcock, as well as their community partners like their FRCs, their family resource centers. Again, the participants were pregnant and newly parenting individuals who have substance use disorders. We didn't specify whether those parents had to be in recovery or treatment. They just needed to have a substance use disorder. And it was generously funded by the New Hampshire Charitable Foundation and the Maternal and Child Health section of the Division of Public Health Services at New Hampshire DHHS. So the overall goal was to support the collaborative development and use of family care plans prenatally in New Hampshire. So that word prenatally is key there. We know in New Hampshire that family care plans often don't get started until after birth in the hospital, since birthing hospitals have the responsibility to notify the state. And so we think this plan would be just so much more helpful if it's able to be started prenatally. And just an overview. So this is a photo of the planners that we purchased. They were 52 pages of content organized into 7 sections. The sections were calendar, notes, the plan itself, health information, as well as baby's health information, a section for consents, a budget grocery meal plan section, and then also some journal pages for the parent. And we had multiple copies of certain forms that we thought they might use again and again, like the calendar and the budget and grocery plans. Of course, there was space for organizations to add their specific documents that they standardly give patients prenatally. And the key part of this is that the planner was to be kept with the person. It was not owned by the clinic or hospital or any other place. It is the birthing person's planner. And that was really important, for to build a sense of ownership of the plan with the family, and also to avoid issues with HIPAA or 42 CFR. And the planner content is accessible online as needed at newhampshirefamilycareplan.org. And so we got a lot of input on this binder planner. The content was informed by the New Hampshire Perinatal Substance Exposure Collaborative, the pilot organizations, a family advisory group that I'm going to talk a little bit more about, and other partners. So the advisory group, while not necessarily convened specifically for the planner pilot, it was convened for the creation of videos, one of which you just saw. And it was comprised of 11 birthing parents with substance use disorder and partners who had children under 2. And we really talked about what is a family care plan and how they should be promoted to families. And this is just some of the feedback. They felt it was really important to use terms like family care plan versus plan of safe care. Plan of safe care made them feel like they had failed, or there was something, they weren't being good parents. DCYF involvement was the biggest concern with receiving a family care plan. They thought it was important to include partners, so husbands, boyfriends, girlfriends, partners in general, in the discussion. And they all agreed that it could be super helpful, but that messaging to the family was key. So here are some of the resources around the planner, and I know my colleague Hannah dropped the links. So we have the planner itself, so you can access that online. We have the video that you just watched for professionals. We also have a video for families. We also have a web page with more resources, as well as for families, parenting resources, and the implementation guide, which was specific to the pilot sites. So that's not available online to the public just yet. And I'm just going to talk a little bit about the videos before I pass it off to Reka. So the video, one of which you just saw, they were 2-minute promotional videos. The provider video was informed by the collaborative, and we really wanted to emphasize that any provider can help start a family care plan. Often it's started by the social worker after birth, and we just think there's opportunities across the providers that a family might interact with to engage them on this plan. And then with the family video, the families of the advisory group really kind of steered the design and promotion of it. They wanted bright colors, they wanted a soothing narration voice, they wanted to hear from both the provider and families, and they wanted a diverse array of families depicted. And we did put a QR code to that video in the planner, and also made shorter versions of that for our media campaign that Reka will talk about later. And with that, I'm going to pass it to Reka.
Thanks, Adriana. So I just wanted to jump to the chat real quick because I think it's an important question for us to just quickly clarify, because it does really feed off of the rest of this presentation and ensuring that you understand the difference between the family care plan and the planner itself. So the question is this taking over for the infant plan of safe care? It is not. So the planner is a physical binder that includes all the sections that Adriana mentioned, in addition to the family care plan, or also referred to as a plan of safe care template. So this planner is just an additional resource to complement what you're talking about in the plan of safe care. And we're hoping that it helps to increase communication and collaboration between the patient and their families and the care teams. So it's just an additional tool to help support that and those conversations around plans of safe care. And it's just being tested at Concord and Dartmouth for now. And it's going to be an ongoing process for us to, look at lessons learned and feedback to determine if it makes sense to roll this out across the state and to involve other organizations across the state that are working with families. So I hope that clarifies a little bit about what we are talking about and how the actual family care plan fits into this pilot project. So I am going to talk about really all of the resources that we've developed to help support the implementation of the family care planner pilot project. So the first resource that we created were 2 videos, which Adriana introduced you to, and one of which you watched. Both were key components in helping us to increase awareness of family care plans across the state of New Hampshire. But to further increase the visibility of these videos, we created several ads to really help really get that out there across the state and within the areas in which the family care planner was being tested. So these ads ran on digital and social media, as well as traditional platforms from November of 2023 through April of this year. So roughly around like 5 or so months. And as highlighted in the table, we ran the social media and digital ads statewide throughout New Hampshire. So that included Facebook, Instagram, TikTok, YouTube, Google search, as well as traditional media, so TV and streaming included things like Hulu, for example. And that was specific to the two communities of Lebanon and Concord, where the actual planners were being used. So our goal of these ads were to increase awareness of family care plans among New Hampshire residents, with the hope that pregnant and parenting people and their families would see those ads, and that it would help prompt and encourage them to inquire more about developing a family care plan with their providers and their care teams. Next slide, please. I can't seem to switch it. Thank you. Okay, so in an effort to help you kind of get a sense of the reach that we were able to gain from these ads, I just wanted to take a few minutes to briefly review some analytics, and that will probably help you kind of see how the two connect with the actual pilot project. So with the traditional TV advertisements, we were able to run those a little over 1,300 times, specifically in Concord and Lebanon. Streaming advertisements were ran a little over 47,000 times, again, in Concord and Lebanon specifically. We also were able to generate ads through TikTok, and that resulted in 364,235 impressions. And this was statewide across New Hampshire. And for those of you that aren't familiar with media buys or, the terminology associated with this, an impression is essentially every time an ad is shown to someone. So this could include the same person seeing it multiple times. So it's not a unique impression. So it doesn't mean that 364,000 plus people saw the ads. It's probably a little lower than that, in that some people probably saw the ads multiple times. And so also part of that is that these impressions ultimately led to people going to the family care planner landing page. So part of that ad was, the family care plan webpage, and encouraging people to go to the page to learn more about family care plans and to, access the resources that are available on the page. We also shared ads through Facebook and Instagram. Those generated lower impressions compared to TikTok, but in general, it resulted in the same clicks to the family care planner landing page. So both or all social media platforms were equally successful in driving people to the page, which is really what we want to happen here. Next slide, please. So these ads directed people to nhfamilycareplan.org. And this page lives off the Today's For Me website, which is specifically for pregnant and parenting people. I think probably many of you are familiar with the website. It was something that was developed as part of a campaign, I want to say roughly in 2018, where the focus was to raise awareness about the effects of alcohol and marijuana among pregnant and parenting people. And so the fact that this was an established page for several years and was receiving traffic already from the population of interest, we felt that it would be appropriate for us to create a page on that website so that we could take advantage of the existing traffic that was already coming to the page. If we were to create a website that was separate to this website, our reach probably wouldn't have been as great as it was. So the family care plan page is specifically designed and written for pregnant and parenting people and their families. It's user-friendly, it's easy to understand, it's appealing, really colorful, and the graphics are, appealing for, that particular audience. And so, it really helps people gain easy access to the planner content, as well as resources related to parenting. So that one is specific to pregnant and parenting people. And then we also created a page off the Center for Excellence website at nhcenterforexcellence.org, which is a substance use specific website for professionals. And many of you may be aware of that page as well, and that resource that exists for folks across the state. This page also hosts the family care plan resources, But the resources that live on that page are very different from the resources that live on the family-facing page, in that, you know, the terminology is different, the detail that's provided on the center website is very different. And so it's really strictly for professionals. And then there's also general information on family care plans. So I highly recommend that you check it out. If you aren't familiar with both of these pages, the links were included in the chat earlier. So, you know, please feel free to take a look at that. And then I'm also curious, just to kind of know if any of you have come across any of these ads, whether online or through the TV. If you have, we would love to know that. Please feel free to share that in the chat. Next slide. So lastly, to support the clinical implementation, we developed a comprehensive guide which provides a chronological list of recommended activities. And so the first section of this guide is specific for staff in our pilot organizations. So that includes Concord and Dartmouth. And these activities are really focused on helping staff to familiarize themselves with available resources. So it encourages them to read the section on family care plans, understand what it is, the importance of it, and how to use it. It also includes information on the family care planner content. So encourages people to, you know, review all 52 pages that are within the planner, understand their purpose and how to use those with participants that are in the pilot project. We encourage them to watch the videos, both the family video and the professional video, as well as reviewing the entire guide. So really trying to help people be well equipped to be able to discuss and use the planner with participants. The next three sections of this guide include chronological activities focused on participant interaction. So it really helps to walk through the activities that are essential when you're introducing the planner to participants, when you're using the planner during follow-up visits, and when you're concluding the pilot project. The guide also includes some general tips. So for example, you know, what do you do when a participant doesn't bring their planner to an appointment? You know, ultimately, we don't want that conversation to be halted in any way. So there's tips on, you know, what you can do if the planner isn't physically available at the appointment. There's also a section focused on data collection processes, as well as a section with additional information about family care plans, including scripts for each participant interaction. So it gives people a sense of, you know, what are the key things that we will want to discuss with the participant at their appointments. So we found this detailed guide really critical in being able to help both teams to understand the activities that needed to take place, but also to help further establish workflows within each clinical practice, really helping them think through, you know, all the different activities that are involved and need to happen, both internally with teams, but also with participants. You know, what does that look like? How are we going to rework or, you know, modify how we're working with patients to incorporate the family care planner? It also helped to ensure consistency across the two locations. Our goal was really to ensure that each of the participants participating in the pilot project, that they had similar interactions with the planner, how it was introduced, how it was being used in a clinical setting, you know, trying to get as much consistency regardless of where the participant was receiving their services. So there's so much more detail that I would love to provide on this topic, but I'm going to stop here, but definitely happy to answer any questions that you have at the end of the webinar. You know, any question is perfectly fine. And with that, I'm going to pass it over to my colleague, Hannah Lessels, who will talk more about participant inclusion, as well as our evaluation protocol. Thank you.
Thank you so much, Rika. All right, so I will be covering the inclusion criteria. So this is for the participants who were part of the pilot, so any patients. And to be included in this pilot project, they had to be 18 years of age or older at the time that they were recruited. They had to either be pregnant or newly parenting, and we included newly parenting in this because we recognize that some folks might be delivering during the time of the pilot, so they weren't excluded once they delivered. They were still part of the pilot after they delivered as a new parent. They had to have a substance use disorder, and they all consented to participate in the pilot. So next, I'm going to cover some of the evaluation information. So our evaluation goals, sorry, there was a delay with the slides. So these evaluation goals we developed at the beginning of the pilot. We wanted to make sure that we identified improvements and additional guidance that may be needed to enhance implementation processes of the planners. We wanted to understand the participant engagement with the planners, and we wanted to identify improvements specific to the planner's contents. So that covered the process of using the planners and the actual content within the planners. So with these goals in mind, we developed several evaluation methods. We had 4 different methods, which included the engagement tracking form. And this is a form that the care team fills out every time a patient brings their planner to a new appointment. So this was filled out when they were all given their planners, as well as every time that they brought their planners back. And we did this using an alphanumeric code that was unique to each planner. That way we weren't tracking any information about the patients themselves, just when the planners reappeared at visits and what types of visits those were. So we got a sense, we were able to quantify the amount of engagement that we were seeing from the planners. We also had our improvements tracking sheet, which was filled out by the care teams at the pilot sites, as well as by our JSI teams anytime that we heard feedback. And these were suggestions for improvements either to the process of using the planners or to the planner content itself. We also had feedback surveys, one for the care team and one for the participants, that are given at the end of the pilot period to share feedback on how everything went, on how the process went, and how the content was, and then suggestions for how to improve things. And then we also had qualitative data collection methods that we developed during the pilot period, including closeout interviews with the participants and a care team debrief meeting. And on your right there, you can see just what the care team feedback survey looked like. And that's just an example of one of those methods. Next, I'm going to talk about our CQI meetings. So during the course of the pilot, we've had bi-weekly continuous quality improvement meetings, and those have been between the JSI perinatal team and the JSI ECCS team, which is the Early Childhood Comprehensive Systems team. It's a team at JSI funded by the New Hampshire Department of Health and Human Services to help healthcare organizations and early childhood care providers strengthen their ability to connect families with children under 3 and prenatally to the services that they need. So it's between our JSI perinatal team, the ECCS team, and the Dartmouth-Hitchcock Medical Center care team and partners. And so these provided the opportunity to problem solve, identify issues with the planner pilot, collect care team and partner feedback, and to make decisions around improvements to the process and planner content. So 2 examples of this, one of them would be the consent checklist. So during one of these meetings, a care team member expressed the need for a more user-friendly tool with which to discuss the consent with patients, something that was both visually clear and accessible to patients, and also broke the information down a little bit more and explained it in clearer terms. And so we developed our consent checklist, which was something they could have with them during the appointments when they're giving out the the planners to their patients. And so they could walk them through each aspect of the consent and make sure that they gained their verbal consent on each of them and were able to answer questions and give them time to kind of absorb the information. Another example of something that was developed out of the CQI meetings was the participant closeout interviews. So during one of these meetings, a member of the care team identified that they had certain patients that might have more to share, that might prefer to share feedback in an interview format, and also just had more information to share beyond the scope of just the questions within the patient survey. And that also the patient survey, they might not prefer to write all of their feedback down. It might be easier to share that and get the nuance of that through an interview. So we developed methods to do participant closeout interviews with all the participants. And next, I'll be sharing just some results from our engagement tracking. So this is from the engagement tracking sheet, which was intended to track the participation, including the frequency with which the patients brought back their planners to appointments and the various settings in which the planners were used. So through this tracking sheet, we had 11 planners distributed to the participants, to folks who had consented to be part of the pilot as patients across the 2 participating sites. We have 22 engagements tracked to date, and those engagements can be anything from like an OB visit, a weight check, home visiting. Some of them were family support or social work consults. So it's a really wide range of visits that were tracked. And so far, 5 of the planners have logged at least 1 follow-up visit. And so that gives us a sense of how often they're recurring in the care settings. And next, I'm going to pass it off to our colleagues at Concord Hospital.
Thank you, Hannah. My name is Melissa Devine. I'm the Women's and Children's Service Line Director for Inpatient Services here at Concord Hospital. So I'm just going to talk a little bit about our project goal here, and then I'll be handing it off to a couple members of my team. First of all, I just want to thank the pilot team, the project team, for having us participate in this pilot project and for allowing us the autonomy, I think, as a site to make the binders a little bit unique to Concord Hospital. To include information that's pertinent to our workflows, to our education. I think that really made a difference in our process and the education we were able to provide to families. So overall, our project goal was to take 5 of these binders and connect with patients with substance use disorder to help better support them. As mentioned previously, this was a tool. It was not to replace the plan of safe care. It was simply to augment services and connect patients better with resources, whether it be here in our regional health system or within our community. We also looked at this as an approach to revamp our substance use services here within the Concord Hospital Health System. Over the last year, we've done a lot of work with our team for education, for trauma-informed care, screening points during the prenatal course and inpatient periods. So we really did use this as a tool to augment our services. It tied in nicely to educating and connecting with patients and really helps to align patient expectations during the prenatal course as well as on admission. Pre-COVID, we have that pre-COVID stage, the post-COVID stage. Pre-COVID, we had what was called a pre-admission meeting for our patients with substance use disorder, where they would come in and meet with a provider, a member of our provider care team, so a pediatric hospitalist, a member of our special care nursery nursing team, our social worker, and other ancillary staff that they may request to meet during their stay. During this pre-admission meeting, we went over lots of different things. We went over what to expect when they were admitted, how long their length of stay might be, and just other things that may come up during their stay that maybe they didn't anticipate prenatally or hadn't thought about, that we could really hone in on educating them so that they felt prepared when they were admitted to the hospital. So we took this project as an opportunity to re-implement that goal and bring back those pre-admission meetings now that we had kind of a tool to center us. So we use 2 of our 4 prenatal offices. We have a Concord and a Laconia site for our Concord OB practices. And from our Concord site, we engaged 2 patients, and our Laconia site, we engaged 3. Our resources, again, pre-COVID, post-COVID, are a little bit different. We have 1 inpatient social worker. We had previously an outpatient high-risk social worker. And she is no longer with our organization. She chose to retire, which is great for her. But our resources are definitely a little bit limited here. So we had our inpatient social worker who does cover inpatient and outpatient now. And then we had a registered staff nurse who was a previous nurse navigator within our system and had previous connections with substance use disorder patients. And so she took this on as a project for herself to use this pilot project to help reconnect with patients and reconnect our system with pregnant persons with substance use disorder. We also engaged our provider groups within our outpatient offices to educate them on the pilot project, as well as engage them during the prenatal course at the patient visits. And I will hand it over to Angela Wilson to talk about our implementation strategy.
Hi, I'm Angela. I'm the Women's and Children's Social Worker for Concord Hospital. So just to recap on what Melissa has already identified, our goal here was to implement 5 binders to 5 different pregnant persons across our 2 Concord Hospital locations, and that includes Laconia and Concord. Again, we did have 2 at Laconia that engaged, and then 3 pregnant women that engaged from Laconia. Myself and Rhonda Chase, who is the registered nurse that participated in this pilot, worked collaboratively together to connect with these women. We worked very closely with the management team at both our Concord Hospital and Laconia practices to identify the participants who would be appropriate and willing to engage. And then Rhonda and I worked together to figure out how to best engage them at what points in their pregnancy were going to be most valuable for them. Again, as mentioned before, ideally this binder and the plan of care is most valuable if started early on in a person's pregnancy. However, there are challenges along the way depending on the individual circumstances of the woman. But Rhonda and I really worked hard with the locations to try to get these binders out to the 5 people as soon as possible. And then within that implementation strategy, we also, like Melissa said, wanted to individualize this binder to Concord Hospital specifically. So we included a couple of components that were specific to our site. One of those being our Eat, Sleep, Console parent tips brochure that does a comprehensive overview of what to expect for families that are coming in and expecting to have an infant exposed to opioids. And so that goes through, how we implement Eat, Sleep, Console here at Concord Hospital and how the parents can be a central aspect of that. We also included our breastfeeding policy, our Hello Family brochure, and brochures around home visiting programs that we've collaborated with in the past to complete these plans of care. And then we included my contact information as well as our postpartum support counselor, who is pretty unique to Concord Hospital. We have one dedicated professional who meets with women prenatally and postnatally up to a year post-delivery that provides postpartum emotional support specifically. So that information was included into the binder to provide to these 5 women. Additionally, as Melissa also mentioned, we wanted to really use this binder as an opportunity to reinstate the pre-admission meeting that we had been using quite readily before COVID. We had developed quite a valuable process in which we would identify substance using women in their pregnancy who were going to be delivering at Concord Hospital, whether it was active substance use or actively in a medicated assisted treatment program. But knowing that there would be a lot for them to understand on what to expect when they came in to deliver, we found that having a meeting prenatally at the hospital where they could meet myself, a pediatrician, and other members of the clinical team really was beneficial. And unfortunately with COVID, that got kind of, distracted from, we weren't able to implement that as much. And so this binder definitely helped us to reinstate that. And we were able to, I think, at least have one binder participant also participate in a pre-admission meeting prior to her delivery, which was awesome to be able to get that up and running again. And I think the only thing I didn't mention in that is that we typically try to have these pre-admission meetings occur anywhere between 34 and 36 weeks of their pregnancy. If we do it too soon, a lot of things change with their pregnancy circumstances. And then obviously, if we do it too late, we may not capture them. So we have found that 34 to 36 weeks is an ideal time to try to bring them in and have a conversation about what to expect. And so I think with that, I'll turn it over to Rhonda.
Rhonda, you're muted. So I'll introduce Rhonda while she's figuring out her audio. So Rhonda, again, is our previous nurse navigator for our service line for high-risk OB patients, and now she works as a staff nurse, a night nurse. So her patient interactions proved to be a little bit challenging along the way, and I know she'll speak to that a little bit once she can start her presentation. I see her eyeballs going up there too. Looks like you're unmuted now. So Rhonda has been really great, and she's formed a lot of connections with our outpatient resources when in her nurse navigator role, and now within her staff nurse role, we've been able to really advance and use her previous experience as a jumping point to really connect and engage with patients on a different level. Still muted. So I'll start patients for Rhonda. So she was able to, she did collect 5 different binders and was able to meet with different patients throughout their prenatal course. And this slide just shows a little bit of an overview of the patients that she was able to connect with. Again, 2 in the Laconia office and 3 in our Concord office. There was an array of whether it was a first or second baby or 4th or 5th baby for different patients. All patients had unique challenges, whether it be transportation challenges, housing issues, or perhaps they were having trouble getting connected with community resources. However, all of them, as you can see, were involved in an MAT program. The first patient, a planner was given. Rhonda was able to meet with her around 38 weeks. She was able to deliver a child within 2 weeks after their initial meeting. Again, the autonomy that the pilot project team gave us to implement and strategize at different points in the prenatal period was super helpful.
Can you hear me now?
Yay! I'm glad we connected on our notes yesterday.
Me too.
All right, go for it.
Were you just talking about the first patient?
Correct, yep.
Okay, so yes, I met with her initially at 38 weeks and she delivered 2 weeks later. She had a lot of questions and concerns about what to expect, which I think we were able to allay. She's been sober for a year and does see a LADAC counselor. When I connected with her postpartum, she said she had moved and misplaced her binder, but did give me her email to share. The second patient, when we initially spoke and I explained the pilot to her, she said she was at work and would think about it. She did agree that I could call her to follow up, but never answered or returned my calls, and I respected that and didn't just blindside her at an appointment. The third patient is her 4th baby. She had a plan to place the baby for adoption. Angela and I both traveled to Laconia to meet with her, but she did miss that appointment. Angela did meet with her later, but the patient was on a bicycle, so she was not able to take the binder home with her. We did leave it at the office for her, but she said she never received it. She's also in a treatment program and does see a LADAC counselor. The last 2 patients received their prenatal care from Concord Hospital, OBGYN in Concord. And they were probably the most engaged of the 2. The 4th patient, it was her 3rd baby. We had worked together during previous pregnancies, so it was fun to reconnect with her. She's very stable on a long-term program. I did visit her postpartum, and she said she brought the planner with her to the hospital, and it was very handy to keep all of her hospital papers in it. The 5th patient, it was her 2nd baby, wasn't able to meet with her and her fiance until about 28 weeks because of some ride challenges that she had and the spacing of appointments. But they both had multiple questions about social supports and resources. She's been sober for 9 months, very excited about her recovery, had completed an inpatient program, then IOP, and is also connected with a mom support group. We were able to tour them through the family place, and she was able to meet some of the nursing staff and Angela so they could connect to schedule that pre-admission meeting. She did let me know that she needed a car seat, and the family place was able to provide one, which she found very helpful. And when I talked to her, I called her a couple of weeks after she delivered, and she said that the binder was helpful to set her up and help her accomplish her goals. Interestingly, I was able to be her labor and delivery nurse, so that was super fun. Some of the successes that we had were, I think, just being able to meet with them prenatally. There's a lot of anxiety that they have about being judged and lots of questions about DCYS. So whatever we could do to help them feel more comfortable is a win. Prepare them for what to expect, like Angela said, the pre-admission meeting. They had great questions. We were able to customize the binder, like Angela said, by adding information about our organization, materials and workflows. And we were able to form connections with them to the point where they would call me with questions and concerns, which was awesome. And like both of the others have mentioned, one of our hospital-specific goals was to restart the pre-admission meetings. And I think that was done. It wasn't done for all of the patients because some had already delivered there and some just delivered too quickly. Some of the challenges that we had were reaching patients by phone. Voicemail boxes were sometimes full, or the numbers were temporarily disconnected. Interestingly, 2 of them gave me alternate numbers when we initially met, so that was helpful. Because of my work schedule, I couldn't always get to their first appointment, and prenatal appointments are sometimes scheduled with weeks in between them, so it did cause some delays there. There were multiple cancellations or last-minute appointment changes. As I said, one walked her bike to appointments, weather permitting, so that caused some issues for her. Others relied on, their partner or other people for a ride, so that, made some, gave them some challenges. The binder was not utilized at appointments by our providers. And as Melissa said, we do have limited outpatient resources in our system for support of this program. Initial feedback when I first gave them the binders was that it was, wow, that's big. Never heard it again. And we did not get a lot of feedback about the content and usefulness of the population. I'm hoping that will come out in your survey. Any questions? Nope.
Thank you, Rhonda. I think we'll now turn it over to the Dartmouth team. And we appreciate questions in the chat or after as well.
Yeah.
Great. Thank you so much for inviting us to talk about our pilot participation. I'm Bonnie Whalen, a general pediatrician who specializes in newborn care in the inpatient newborn nursery, and Megan will introduce herself when she speaks in just a few minutes. So just to share a little bit for you all on the call where we are and who we are, we're about an hour north from Concord, New Hampshire, who you just heard from. We're a rural academic medical center set in this beautiful setting, as you can see, in Lebanon, New Hampshire. And our children's hospital is actually set within the academic medical center, and our prenatal clinic is on one side of the hospital, inpatient unit in the middle, and then for the newborn nursery and the intensive care nursery, and then our pediatrics unit is kind of down a long hallway into another part of the hospital. So it's for families coming into the system, a rather large medical center. But I would feel like for us as our group, we really have nice partnerships and close interactions across our disciplines. We partnered with the Family Place in across the river in Vermont, in Wilder, Vermont, and with a family, the TLC Family Resource Center, sorry, in Claremont, which is south of us. And you can see on these maps, Claremont is anywhere between like a 40 to 50-minute drive, depending on where families are located within that kind of commuting route. And then the Family Place is only about a 13-minute drive from our medical center. So we really serve families from both New Hampshire and Vermont because of where we're set right on the border of both states, kind of right on the Connecticut River. We had 2 main project goals for our participation in this project. We really wanted to introduce the family care planner binder at the first opportunity for qualifying patients and families in our varied care settings. And ideally, that would be prenatally, to really be able to help engage the pregnant parent and then help them through their different kind of clinical courses and clinical care settings. We have a Purple Pod prenatal clinic, which is a substance use disorder specialized clinic that's staffed by OB providers such as Daisy Goodman, who's a nurse midwife, other OB providers, including OB residents that are interested in specializing or caring for families with substance use disorder. And also there is a community health worker, Katie Roby, and a OB social worker, B. Newing, and then Megan Adams, who's the recovery coach, community health worker, doula, and who's becoming specialized in lactation as well. So that's a really nicely resourced prenatal clinic. And then our birthing pavilion, which houses our newborn nursery, intensive care nursery, any babies that are born less than 35 weeks, less than 1750 grams, or with high intensive care needs, go to the intensive care nursery. And our two main community partners for this project, as I mentioned, were the Family Place and TLC. So we had hoped to introduce Pre-natally the family care planner, but if any family introduced themselves for the first time among our other clinical settings or resource settings, we were going to introduce there. And then really hope to reinforce the use of the family care planner, a binder at each additional opportunity. So in these prenatal visits in the clinic, but also any home visits that were able to occur, or any prenatal kind of contacts that families had with any of their resource support people, and then the inpatient stay in the birthing pavilion, newborn nursery, and intensive care nursery, or if a mom needed to be admitted someplace else in the hospital or pediatrics unit. And then post-delivery visits, so postpartum visits for the new parent, or primary care visits, or for the baby primary care visits, or in-home visits, primarily with the Family Place and TLC, but also ideally with home visiting, like visiting nursing association. We formed, and when I say we formed, we really reformed our multidisciplinary care team. Similar to Concord, we, prior to COVID, really had a well-established system for prenatal visits and kind of a community of care, DHPOSC QI implementation group and planning group. And really with COVID, we were just all acting in the moment to the best of our ability. Prenatal visits and education that occurred with our parents at the Moms in Recovery group, we weren't able to do in person anymore. And then we weren't able to really engage like prenatally through telehealth for that. And so we were all just, I think, doing the best that we could with the resources at that time. And this really provided a great impetus for all of us to get back together. And then we also had new staff on, and our prenatal purple pod was really more resourced with the individuals that I mentioned, that were not the same individuals kind of pre-COVID or even early COVID. I mentioned the prenatal purple pod. Our three main kind of champions there were Megan, B, and Katie, as the recovery coach, community health worker, and social worker supports. And then I served as the main kind of contact person and really champion on the newborn nursery inpatient unit, as well as Mary Haran, our inpatient BP newborn nursery social worker, LaTanya Johnson as our intensive care nursery social worker, and Katrina Cameron was a per diem social worker that used to work full-time for us in the prenatal and inpatient setting, but now is per diem. But she really helped with one family that I'll share in particular. And then, as I mentioned, the Family Place and TLC, we had leadership from both of our community care partners there, as well as their home visitors. And just sharing again here on the map with DH is a little medical center in blue, Family Place is across the river in the dark green, and then Claremont, the resource center, TLC resource center down in Claremont is in the light green. Our successes, we were able to engage 8 families in accepting participation in the pilot project. We actually received positive initial feedback, even with the size of the planner, which I think all of us, when we got the boxes, were quite surprised how big they were. They were wonderful, but they're really kind of a zip up binder that's able to house everything. And so families really liked that they could put things in there and wouldn't worry about them falling out, and were not overwhelmed by the size of them at all. Our prenatal clinic did a really awesome job in handing out and engaging 4 families prenatally. 2 were handed out in the intensive care nursery and 2 on our birthing pavilion with a newborn nursery. But out of those 8, we've really only had 2 of the 8 families really engaged with the planner in terms of having multiple visits that they've used the planner with. So one family engaged initially with the planner in prenatal visits, and then after that initial visit, they brought the planner back to 2 prenatal visits, and that pregnant person has actually gone beyond our DH Lebanon clinic and has gotten weight checks prenatally in Nashua and has used the planner and kind of logged the planner there. And I'm sharing where these planners are used, and this is really us identifying by the planners being scanned with the QR stickers codes at the back. They may be used in other circumstances. We haven't had full feedback or kind of pilot participation feedback with the families. So families may be using them, but just not logging them. And then our second family is a family that engaged prenatally, in the intensive care nursery for their first visit. And then we have had them use the visits with the family place with 3 of their home visits with Lauren, the family place home visitor there. And then they brought their binder for a DH well-child check with Dr. Steve Chapman. And this required some coaching in terms of the family bringing it, and then my individualizing some coaching with Dr. Chapman to anticipate receiving the planner and really asking. I just include this really nice table of contents that shows you how much information is housed within this planner and how it's organized by calendar, notes, their family care plan, the birthing parents' own health information, and then the baby's health information, or all of kind of their resources. And then for the birthing parents' consents and releases of information, and then some family care resource tools, as was discussed earlier. So I'm going to turn it over to Megan now, and she's going to really share a little bit how she approached sharing the planner with families in the clinic. And Megan has really been just a champion for our participation in the pilot. So thank you, Megan.
Of course. Hi, everybody. I'm Megan. As Bonnie said, I'm the recovery coach, healthcare navigator, doula, and I'm taking the lactation training right now to be able to provide that to our moms. I have kind of a unique experience with this. Sorry, my child's sitting next to me and his phone's blaring. Prior to having this little, Prior to having this little angel sitting next to me, I was in the throes of addiction for like almost 17 years prior to having Dylan. And when I found out I was pregnant with Dylan in 2019, I knew that if I didn't do something drastically different, there was going to be absolutely no chance of me parenting this child. So when social work suggested something to me, I did it. When a clinician, a late act, a provider, anybody that suggested anything to me, I did it because I was so desperate for some relief from my struggles. I also had a family care plan for Dylan. And when Bonnie introduced the family care planner to me, I was just like, wow, this would have been so helpful to me. I was just so desperate to do things, you know, quote unquote, correct and right. Okay, go over there with it, honey, for just a second. And what my first, hold on, honey, I'll help you. My first thoughts from it were, what a fabulous way to put the power back in these patients' hands. You know, between the family care plan and the family care planner, they just complement themselves so well. And this is kind of skipping ahead, but I talk about this when I introduce the planner in clinic. I really just try to say that, like, the family care plan, this is, you know, don't look at it as shameful or, you know, this is because I'm bad. Like, use this to show your strength. show your supports. Like if you're involved with the Family Place or TLC or Moms in Recovery, be proud of that. That's something to be proud of. Like you're constantly working on yourself, and that's something we really want to highlight for you. So we just really flip-flopped back and forth between the planner and the family care plan. Social work was also really big in helping us do that. What else was I going to talk about with this? Yeah, just having everything live in one place is so helpful. I think in the beginning, early on in recovery, things are so very stressful. And if things can live in one place, I would often say, like, after you use the planner at home, put it back in your diaper bag if you think of it, so that when the baby's crying, you're trying to get out the door, you're already 5 minutes behind, the planner's in your bag and you have it when you get there. And make notes of things. I would used to think, oh, I want to ask about this or I want to ask about that, and then you get there and you can't remember any of your notes. Like we would encourage them to write things down. People really loved the budgeting and the calendar. I even used the link to print out the budgeting paper for myself, and I've used it several times, especially when I needed to get a new car. Was very stressed how that was going, to do that responsibly, of course. And to just really, like, after my child, like, my job is everything to me. To work and to walk through the things that I've walked through, and then to be able to tell people, like, just keep doing the next right thing, get into moms, get into any type of recovery support, and just keep doing the next right thing, and things will fall into place. These patients want to parent so badly, and with solid recovery, it's really doable. What's hard is since xylazine has come into the mix, I think of course, everybody's had challenges when it comes to getting people to use the binder. It's because things have never been as grim as they are in the world right now. We go through waves on Purple Pod where we have some really big successes and then we have some really hard falls. What's nice about my role is I tell them, like, if you're not ready for recovery, like, I'm still here for you. I still want you to be safe. I still want your baby to get here safely, whatever that looks for you. And really being upfront with them, and never telling people things out of fear, but saying, if we can't get you into a good place prior to your third trimester, like, this is typically what things look like, so that they're never blindsided when they get to the birthing pavilion. The multidisciplinary teams that we have, we work so well together. That's something I'm also really proud of, between, Bonnie and the newborn nursery, the birthing pavilion, OB clinic, the Moms in Recovery. That's a Dartmouth. It's not housed at DHMC, but it is in the River Mill. We work tirelessly with them. So all of these things together to just really give people the best chance they can to parent these kids in a way that these kids so desperately deserve. So I'm happy to answer any questions or comments after, if anybody has any. So thanks.
Thank you so much, Megan. Yeah, and I remember, Megan, you just really shared, like, this is a binder that a family can really keep all of their information in to help organize themselves, but it's so incredibly helpful for us as the providers, or you as the recovery coach, do you remember I gave you this information? Let's look back at that, and where your information or lives in the planner, and that you can reinforce or go back to. And I love Concord with you guys really individualizing the planner with all of your own information and kind of using that in the way that's helped you. And I agree. I think it's really nice to be able to individualize this to our own care settings. So I just wanted to share a few of our action steps that we've taken within the project, and then a little bit about the kind of successes and challenges. We did use our funding for the project to give a $25 initial thank you card to families for agreeing to participate. And then for each visit or encounter that they used with a provider or resource individual, that if they scanned the QR code on the back, or it was entered via a website, link that they would get a $10 credit for each additional use of the visit as an additional thank you. I personally provided phone feedback and coaching with the first 3 pilot families, or received feedback from them and provided coaching. And I'll speak to one family that really engaged with the pilot and shared some really great feedback. We created something called EDH sticky notes. So EDH is our computerized medical record, and developed these smart phrases, links that we could quickly drop into the comments for the prenatal providers and the pediatrics providers to try to communicate when a family was in the pilot project. And then I individually provided outreach education and to individual resources or providers that the patients that were participating in the project were going to be seeing, and then requests for them to help the families scan in their QR codes. So that included our prenatal purple pod director, Daisy Goodman, the Moms in Recovery program. I met with their whole care team there. And then I provided individual contacts to PCPs and providers at the DH Purple Pod Pediatrics in Heater Road Primary Care, Elliott Pediatrics in Manchester, Cheshire Pediatrics in Keene, South Royalton Pediatrics in Vermont, and Nashua DH Pediatrics, trying to connect with the baby's primary care provider primarily, to ask if to introduce the planner, what it was and how we were using it, and hoping that they would engage in its use with the family and help them scan the code. And then with one particular inpatient baby that the mom was actually going on to an outpatient residential treatment program, I provided some in-time education with our intensive care nursery residents and the social work intern to try to use the planner with that mom, and then a community health worker that works at the Women's Health Resource Center in Lebanon. This is the one family's testimony that I wanted to really just share about. So one family that was engaged with the intensive care nursery, they loved the planner. They loved everything about it. They loved how it was organized, the calendars, pregnancy journal, resources. They felt like it had everything that they needed to get started and more than they felt like they needed, but was really valuable. And they gave me this beautiful quote of really in a kind of ocean that's all blue. It really helped them feel like they had a direction to go in, whereas they had been floating in kind of the ocean. So there's so much information coming at you, and so much to do and know to be a new parent, and this really helped them go in the right direction. And they had actually a similar medical planner for their 6-year-old that they had been using the whole time, but they love the organization of this, and they reorganized their 6-year-old's planner to help kind of in the way that they were thinking about their baby's care. They gave some great feedback for JSI in terms of how to improve the planners. And one of the most important ones was really having a particular section to involve the dad or partners more, or at least in the language in the planner. And I think I'm gone over a little bit of time. So really quickly, challenges, just like Concord was sharing, I think we recognize that families were really going to have a hard time just remembering to bring the planner to appointments. And I've shared widely that I have a hard time remembering to bring my schedule. But we also just saw other challenges, like the providers and resource support weren't aware of the planner, even despite individualized education provided. There really was a significant amount of time and effort needed to familiarize and coach patients, individual providers, and community supports. And I see that Concord, Rhonda, really you were key in helping do that. And not all hospitals are really going to have a champion like that or a coordinator that's going to be able to help do that. But families do need that extra care coordination. Providers that were educated were actually not the ones that ended up being the one providing the visit because the other provider wasn't there or the family had to reschedule. Families came late to visits, and so they, were 45 minutes late for a visit and were able to see the provider, but there were so many other things needed to be taken care of in that well child visit. And then just kind of as Megan was mentioning, things like xylazine and active addiction, that trumps the need to like review the planner and go over is like what is needed in this moment to make this patient be safe and get the right care that they needed. And there's so many other visit needs that are present. And then for us at Dartmouth, we're really still working on communication between our different care units. And even though I think we have a really great team and great communication, when we have one family planner or family that's involved in a planner, like I've been the newborn nursery championing about this, and I was horrified to learn at one of our meetings that I actually missed a family that I had taken care of over a weekend. I had no clue that they were involved in the family care planner pilot, and it's just everybody's busy and working, as hard as they can. So still opportunity to try to find ways that we can improve in that. And then in talking the Moms in Recovery program, we learned that they really need a 42 CFR consent signed for use to be able to like even log the planner for the family. So that's something that a 42 CFR consent form needs to specifically be included in all planners. As I mentioned, our opportunities at DH are really improving our communication between clinical settings. We have shared with JSI that we think would be helpful to have an additional like patient testimony video about how impactful the planner is, or it could even be like Megan sharing how impactful it is, or the one family that I mentioned that they've really engaged in the family planner. We would love to see this be something that families could use using their smartphones or a web-based app, so that if they didn't remember their planner, that they could go on their phone, or the provider could go on a web app and really help to like put information there or show them in time and kind of document for them. And then I think just highlighted in everything that Megan's really doing and helping families in all of the different roles and training, and what Concord's doing is I think some families really need like one person to be that person for them that helps them get across all of these clinical settings, helps them remember things, helps them like reschedule appointments if they've needed to cancel or reschedule or missed an appointment, and really helping provide warm handoffs from providers, one provider to another, one resource person to another, and just that trust and rapport that can come from knowing individuals and sharing by name. So I'll stop there. I apologize that I went over.
Great.
Katie, are you gonna hand over, or I can see if there's any in the chat?
Yeah, I'm happy to, if anyone wants to unmute and go ahead, and if you have questions to ask of any of the presenters, or please feel free to put it in the chat. See, Reka put information in the chat about the Perinatal Substance Exposure Collaborative and its schedule. Please feel free to reach out to Reka or Cora if you're interested in participating. Is there anyone that has a question in the chat that would like to follow up on any of the responses that you may have heard? Okay, there's a question from Julia Johnston. Have you reached out to wraparound providers or connect these families to the wraparound program? Perfectly aligns with their process, and especially with the point about families looking for someone to be that one person for them.
Yeah, Julia, do you mind just sharing what wraparound is and how available that is for families? Because I'm not sure that everybody on the call knows about that.
Yeah, absolutely. So in New Hampshire, so I work for Connected Families New Hampshire, and we work in the southern and northern region. We have two offices, one in Keene and one in Claremont. So Keene kind of takes the lower half and Claremont takes the upper half. And then there's also NFI that also does wraparound services. And we're a voluntary family-driven process where we create plan of care, kind of similar in this essence, working towards their needs and strengths and goals. And we thank you for the link. And you can refer people right on the website as well. It goes to the state and then trickles out to whichever CME is depending on where they live. And they do, so we have a birth through 5 wraparound program, which would perfectly connect with this family care planner, and just further connecting them with those resources and helping them, follow up with appointments, make plans around parenting and things like that. I can answer more questions. That's a very general overview.
And Julie, I do have a follow-up question. How are you funded, and is this available for everybody? I apologize if you said it.
Oh, no problem. So we are Medicaid funded. The birth through 5 program through Connected Families right now is grant funded, so you don't need to necessarily have Medicaid for that, but it is Medicaid billable funding.
Thank you.
Thanks, Julie.
Yeah, that's great to know. I just wrote that down. I'm definitely going to look more into it. There's so much grant things going on through Dartmouth, but the P2P, they had a WRAP program. I think it went for 5 years, but it's ending in August. So this is a great alternative for that. So I'm definitely going to look into it. Thanks for sharing that.
Yeah, absolutely. Feel free to reach out to myself anytime, and I can definitely connect you with further supervisors and managers at that organization.
Thank you.
I just dropped a few. I know we just have about 6 minutes left before we wrap up. I just wanted to offer or just pose a few questions for participants to kind of consider and share your thoughts. Feel free to pick any one of these. So given the identified challenges, how would you suggest to improve family care plan utilization? What community partners might you leverage to further this work, and how does this work fit into the larger activities happening within your organization with this community?
Hi there, this is Lisa Spears. I actually work for AmeriHealth, but I just had one question. Have you leveraged the MAT programs or, like Hope on Haven Hill or any of those programs to see if they'd be willing to start either the plan of care or this? It seems like, they see them at least weekly or if not monthly. So I didn't know if that was something that was on the table or not.
Yeah, that's a great suggestion, Lisa. And we actually, our internal team was brainstorming, what are other settings where, use of the planner might be more appropriate, given the challenges that were discussed by Bonnie and Melissa and others on the team. And Hope on Haven Hill, like the residential treatment programs, we were thinking maybe that's something to test this out with. That, those folks are there 24 hours a day and, there's more interaction and time to really, dive into what's available in the planner. So we have been talking about that and potentially, may consider that, for maybe a part 2 pilot test.
Yeah, I know they provide lots of education. And so if they, maybe if the pregnant women or the newly delivered were used to using it as a resource by living when, if it's, every day they reviewed it or whatever, not every day, maybe every week, it wouldn't feel so awkward to refer to it if it was something that was consistent, a habit maybe.
Yeah, definitely.
Thank you, Lisa. There's another question in the chat. Is there going to be a larger opportunity to use this among all families instead of only those with SUD? Anyone from the team wants to take that question?
That's the ultimate goal. We would like to make this a resource for, any family, because I think it would be helpful for anyone, not just those with substance use. But given that, we only had so much funding available to support this pilot project, we were only able to, try this out in Concord Hospital and Dartmouth. with a small number of participants. So we had 35 planners that we were able to put together, within the 2 locations, and really started with those that have substance use disorders. But ideally, we would love to roll this out statewide with all families. It's just a matter of, we wanted to start small, really test out what the successes and challenges are, and, think about that to help inform what future expansion might look like.
And Rika, can I just add to that too? So the materials are available online, so anybody could print them out and choose to use them and get a binder and put them in. It's just a matter of whether your organization has the resources behind it, the care coordination, as we heard, like this was very resource intensive in terms of time. So, I mean, in theory, anybody who wanted this planner could use it and print it and engage families. It's just a matter of whether you have the team behind it and the care coordination already set up to support it.
Thanks for mentioning that, Adriana. And we offer technical assistance. So if you decide that you do want to try to launch this within your program, we're happy to meet with you and, really coach you through what this looks like within your setting and how to implement. So feel free to reach out to us if that's of interest to you. We can absolutely help support the implementation of this within your program or practice.
And Sarah Fox, would you be able to unmute and just share about this new newborn navigator role program? Or anybody else on the call that knows about it?
Are you talking about for home visiting or? Oops. Okay. Thanks, Sarah. Well, I have Virginia is on the phone right now, and she's the program manager for CFSS. So if I can pick on her if she's still on the call. But we have a statewide home visiting program called Comprehensive Family Support Services, and it covers the entire state of New Hampshire. We kind of utilize the district office, the DHHS district office catchment areas, and that's kind of 11 agencies cover each of those catchment areas. So there is in pretty much every community a home visiting program under that. And then starting next fiscal year into July, there's going to be an enhancement to that where we're specifically going to be working really closely with medical providers and pediatricians and just anything that's in the community, right? To try to enhance enrollment with newborn families in particular. So the goal there is to really try to get families connected as early as possible, potentially, enrolling prenatally, but really wanting to have kind of a touch point after birth to do things like maternal depression screening, attachments, feeding, just all of those topic areas that are kind of going to roll up, especially postpartum, and help connect the family as early as possible. So we could potentially go out a couple more times or, enroll formally in a home visiting program. It's really going to be up to the family, but we're excited about it. It's definitely a area of, just primary prevention, really trying to work with families as early as possible in a kind of really a normalizing way, because when you come home with a baby, like we just heard, there's a lot. So that, I don't know if that answers the questions that was on that. If you want to learn more about the CFSS program or any of the home visiting programs we have, please feel free you can check out our website, and I can put that in the chat. Yeah, so I don't know if there's any questions that anyone had about that.
Yeah, that information in the chat would be great. I know that we just personally at DH in our Upper Valley area and sending families home have struggled with even just getting home visiting nursing. So I'm going to guess with this, there's extras like maternal child health staffing that's been hired or being hired to help accommodate this.
Yeah, so each of the CFS agencies are identifying a staff that's really honing in on newborn navigation and all of those topic areas. And so it may take us a few months to really just onboard and make sure everyone has, all of the same training so that we're all, talking the same talk. And also just making sure that they have kind of that community alignment with those resources and can kind of engage folks with referrals and kind of developing those partnerships. We don't want to duplicate efforts, so it's just important that they kind of build out that natural team of multiple programs that touch families to make sure that, it doesn't have to be our program at CFSS. It could be Healthy Families America that's a better fit. So we want to make sure that that cohesion happens.
Well, I want to thank everybody. Athena, thank you for adding that context, and Bonnie for the follow-up questions. We are 3 minutes past our end time, so I'm going to wrap us up. And again, thank you so much to all of our speakers. Thank you to the pilot project teams who are involved, to the JSI team. This was a great example of some creative, innovative ideas to pull together some different funding streams to try out something new. So we hope you all learned something from today's webinar. In the chat, we have put 2 links in. One is the evaluation for today's session. Please take a quick minute after you hop off to do that. The second one is a link to register for the 4th and final webinar that's part of the ECCS project, which is closing out. And this will be a partnered presentation from the Healthy Homes Lead Poisoning Prevention Program at DHHS and partners at the Belknap Merrimack Community Action Program, staff from their Early Head Start program. So we're excited to share some innovative strategies for how programs are working to support families facing lead poisoning challenges. So again, really appreciate your time. Thank you all to the presenters and for the folks who put in your questions. And hope you have a wonderful weekend, and we will talk soon. Have a great day.
Thank you so much.